First, I would like to request team 1. Dr.
1
K.
minute, please.
Nanda Chandrakant from Gilpak Medical College, Chennai. Your first spotter is this. I would like to request Lakshmi ma'am and Ramakant Bembesa to be the lead panelist for this session. Your time is 10 minutes.
Rohit,
Good evening,
Good evening,
Ramakant sir
ma'am.
is there now?
Good evening.
Yeah, good evening, sir. Good afternoon, everyone.
Good evening, sir.
Yeah. I'm
Please
here.
start it, sir.
Yeah.
All the best to both teams.
Thank you, ma'am.
Ramakant sir, unmute your audio.
Yeah.
Start the session, sir.
This is the photograph which shows 40% mixed flame burns and facial and inhalation lung injury. And the this. I think
if the patient comes to you like this, sir, what is your approach?
Initially we will assess the airway of the patient, ma'am, and when we will assess the airway patency and circulation and breathing pattern of the patient, and then we will assess the percentage of the burns. Once we have assessed the percentage, we will have an IV line access, and we will start IV fluid resuscitation followed by nasal oxygen if the saturation of the patient is maintaining. If there is any compromise in airway of the patient, any signs of inhalation burns, then we will and any there is presence of any hypoxia, then we will suggest an early intubation for the patient as a part of initial resuscitation.
Sir, Ramakant sir, you can proceed.
Yeah. What about you can see that this patient seems to be having a very deep 3rd-degree burns. What about the fasciotomies, ischiotomies?
Sir, don't
sir,
give lead questions. Ask the questions.
Okay.
Sir. This is competition.
Okay.
So
Okay.
expect answers from them. Don't give the diagnosis or treatment from your side.
Okay, got it.
If they don't answer, that has to go to the team 2. So give more questions to them, sir.
Yeah. So what will be your line of management with the management? Since this is a deep burns involving the chest wall, if there is a circumferential chest wall and there is evidence of eschar over the surrounding the chest wall, then an eschorotomy over the chest wall would help the patient.
How it helps the patient, eschorotomy?
The eschar, the circumferential eschar compresses the chest walls, causing a restrictive breathing.
Yeah.
And eschorotomy helps in decompressing the chest walls.
So usually how you give the eschorotomy incisions?
For the lateral.
We put along.
No, where in which is it the same in every area or any difference is there from part to part? If at all you give, so what precautions you have to take, and while giving, how you will give?
We will put 2 eschorotomy incision over both the lateral aspect of the chest wall and
only 2 will be sufficient if there is a circumferential 3rd-degree burns restricting the expansion of the chest wall. Isn't it?
Sorry, ma'am, I couldn't get your question.
No. What type of incisions you give to the chest wall, the abdomen, upper limbs, lower limb? You give eschorotomy incisions for all these areas, isn't it?
Yes, ma'am.
Yeah, fast.
You give eschorotomy incision in chest wall. Both parallel incisions are given on both sides of the chest wall, and inferiorly we will connect both the incisions up to the subcutaneous level. We will make the incision. So
if needed, you have to any improvement for second team 2. Any improvement over the team 1? Can you tell when you give eschorotomy incisions what precautions you have to take and how you have to give?
2 incisions over the lateral aspect of the chest wall and superior.
Yes, that already told. You have to tell additional points.
Superior aspect also, horizontal incision connecting the 2 incisions will be made, and inferiorly also the incisions, the lateral incisions will be connected. This is on the trunk.
Yes. Okay. That is 1 point. What else?
We should avoid major neurovascular bundle.
You don't go that much deep, isn't it? Eschorotomy means you confine to only eschar. You are not doing fasciotomy. Okay. So you will only, that is one precaution. You should not injure the veins or any other structures. Only you give incision in the HR. And both teams didn't answer. I'm telling you, it has to cross the burn area and go to the normal plane. Okay, then only it expands, allow the burn wound to expand, right? And allows the respirations, right? So, Ramakant sir, next question you can answer.
What is
Team
your
one.
plan for what is your plan for wound management in case of deep burns? How will you go ahead?
Sir, since only the upper trunk and neck and both arms are only involved, apparently both the thighs, if it is free,
They
then I
are
would
free.
like, if the patient is stable enough, then I will perform an early excision and autografting as a part of initial resuscitation, sir.
So, what are the indications, contraindications for early tangential excision, and what are the steps? How you will go?
Sir, sufficient, the donor area should be available to perform the early excision.
What?
And
In
Only
tangential
the
excision,
donor area will be sufficient. What else? What all required you should tell.
the early
One is
excision should be
autograft availability, donor site. What else?
yes.
another early excision should be performed within 5 to 7 days. The patient should be, hemodynamically stable enough.
Stability should be there, ma'am. And we do a tangential excision till the punctate blood vessels are bleeding is seen. Where the graft take will be good. Available. The bed is available for the graft take, ma'am.
Okay.
If there is any possibility of autograft, then allograft can also be.
Deep dermal burns is one of the indications for the early excision and grafting.
What about third degree burns? Very deep burns.
For third degree burns, we can go for facial excision, sir, where we can excise till fascia and cover it with a dermal substitute. Further, we can graft it in next sitting.
About the timing of the excision, can the second team give their answers? Timing of surgery.
So the timing of surgery, sir, we have to follow early tangential excision, sir. It stabilize the patient and do it as early as possible, sir.
What is the time duration by
Within
definition?
24 hours to 72 hours.
I think
24 hours.
for both the teams, the correct answer is early tangential excision should be done from. Can I answer or should the answer go ahead? Dr. Lakshmi.
Sir, we have one
Yeah,
more.
now we have time after asking the question, sir.
Okay,
Now
okay.
you can continue because
With the
15
question.
minutes will take for the questions as well as answers.
Ma'am, it's almost over, ma'am. Yeah,
10 minutes over.
10 minutes over, ma'am.
Oh, okay, sir. You can answer the question.
Yeah, ideally the tangential excision should be done after 24 hours till up to max 5 days, because after 5 days there will be chances of bacterial infection or there will be bacterial flora on the wound. So given a choice, it should be done earliest. That is 72 hours is the best time. And there are centers where within 24 hours also, if patient is stable, they are going for tangential excision. So practically, it should be 72 hours is practically more practical. So there will be no chance of bacteremia after tangential excision. And I was asking about the steps. What are the steps? Hello?
Hello.
Sir,
What are the steps? But I think because of paucity of
Sorry.
time, you could not answer. What are the steps for the tangential excision?
we'll give 2% solution over the burnt area, sir. And then we will tangential excision is performed until punctate bleeding is seen from the undersurface.
What is the other criteria? Because you have given the like adrenaline solution. So
the color of
may not appear also sometimes. Viable. Yes.
Still,
What is the
till
definition?
the tissue is pale white in color, we can excise, ma'am, till with the punctate bleeding.
Okay, go ahead.
If we are putting a tourniquet, the
bleeding is not coming because
Okay, proceed.
So till we see that punctate bleed or till the viable tissue is seen, we excise. After that, we put a split screen graft. After giving a thorough wash, we put a split screen graft over the autograft. If autograft is not available, then we can proceed with an allograft.
Ma'am, I could not hear the last few minutes. Can you just respond to them?
What they told is they will tangentially excise the burn wound until the punctate bleed appears or the viable tissue and resurface with the split thickness skin graft. So that is what they told.
What
After
are the, this is the big area.
with,
Yeah. Okay. This is the big area. So how will you manage the skin graft? What are the ways of expansion of the skin graft?
Sir, we'll mesh it, sir. Like based on the area of to cover, we'll mesh it from 1:2. Using a measure, we can measure it from 1:2 to 1:3 and then place it over the burnt area.
What are other options?
there will be problem harvesting such a big autographs. Okay, 1:2 or 1:1.5. It expands
can-
only doubles the meshing, isn't it? Area.
We can do a sandwich grafting, ma'am. Like we can mesh the autograph very widely, put it over the burnt area, then put a give a cover with the
accepted.
allograft.
Anything else also?
Other options used are meat grafting or minced grafts can be used. Very small minced grafts can be used if the burned area is very large and the donor area is very small.
Have you heard of any other technique?
We can use a dermal substitute, sir, like put an integra over it.
Yeah, that is option. But about expansion of the skin?
Sir, they told make micrograft also.
Okay, got you. I didn't heard that. My airport got discharged.
So they told all the types of modalities available for resurfacing, sir.
Resurfacing.
Yeah.
Okay.
So is still time is there, Rohit? 15 minutes over?
15 minutes over, ma'am. Now we'll move to the moderator remarks and questions.
Okay.
Seema, ma'am.
Seema, ma'am.
Yes. Can you hear me?
Yes.
Yes,
Yeah,
ma'am.
Yeah. I would like to ask, what is the percentage, maximum percentage of burn that you can excise in tangential excision? Especially say, suppose the patient is having 40% burn, mostly second degree and, third degree. So which portion you will excise and what is the percentage you will excise at one go? And what the things that is number one. Number two is what are the things you'll keep ready in case, you have some problem?
Ma'am, around 20 to 30% we can excise, ma'am. Deep dermal burns, we need to excise it.
And second is, what is more important and what you should keep ready?
Any tangential excision.
Blood
What you
transfer,
should
ma'am.
keep
There is a lot of blood loss.
Blood loss
Yes.
will be there, ma'am. Minimum
You
2
expect-
subunit. Minimum.
Yes, you expect there will be a lot of bleeding during excision. And if there is
Yes,
oozing from there may be oozing from the wound, of course, you have to take care that, graft doesn't float. But then you must, in most of the tangential excision, you must supplement with blood transfusion. So if it is not second degree deep, if it is third degree burn, will the treatment be the same?
The facial excision we can do, ma'am. Like we go till the level of fascia, we excise it, ma'am. Then we put a dermal substitute and we go for grafting in the second sitting.
So what are the dermal substitutes that you would take?
Integra, we can use it, ma'am.
That is quite expensive, I mean, like not the Integra, if you have any other option. Not that, it can be used in government hospitals, even in private hospitals, Integra, you cannot use because it's a very good thing. But then, yeah, because of
Cadaveric allograft can be used.
Cadaveric allograft can be used.
Yes. So what will you do? Cadaveric graft mashing, and then you will use that?
Cadaveric graft we will get from the skin bag, ma'am. Wash it thoroughly with normal saline 3 times, and then we will expand it and place over the raw area, ma'am.
Yes. Do you ever use? Suppose it's a child Do you ever use graft from the relatives, especially mother or anyone?
Yes,
Yes, ma'am.
It can also be done, ma'am.
So that is the
graft
third
from-
option. Yes, that is the
Uh,
third option. So you can use, allograft live one.
From the parents, from the parents we can
The
take.
parents or anyone willing from the, family. But then you must take precautions, like all the precautions that you take in any, homograft when you use. So all the precautions you have to take, at least do, the viral markers and everything, and then get it done. So that is the third major option you can take. Okay. Then any other biological dressing that you would like to use? Suppose you don't have any, no one is willing to donate. And then
We can put collagen, ma'am.
If it is superficial one, we can go with
any
the
other,
Like amnion membrane coverage we can give.
any other? Tell me about, I'm just asking you about any other biological dressings that you can use.
Bioban we can use.
What is available? Other than the, dermasis or, derma, whatever other options are available.
cultured.
That is an option, but you cannot use it all the time. So are there any other biological substitutes that you can use in the patient?
Acellular dermal matrix like
Acellular dermal matrix.
Matriderm.
There are some silver dressings also available.
Metlix AG,
Metlix AG, Urgatol AG.
Argotol AG we can use.
Yes. So when you do not have any other things, you can use that also. And meanwhile, you can try for in the next dressing or other homographs or the options that we have already discussed.
Judges or any other senior faculty? Ma'am, now your time is over.
Yes.
Next,
Please.
Bhattacharya sir.
Yes. Before going to the advanced areas, I would like to ask, how do you clinically assess the depth of burn when you are telling it is a 3rd-degree burn? How do you clinically assess it?
Sir, 3rd-degree burns do not blanch on pressure, sir. It will be pale white.
Okay, pale white, the color. Okay, what else?
The skin will be leathery.
Leathery in what? In look or feeling?
In leathery in consistency. Sir.
Okay, what else?
And
I'm asking you clinical. Pure clinical.
Differentiation of a superficial and deep burns. Five features are there.
There will be thrombosis of the.
Yes.
Yes.
It will be painless. Patient will not have any pain.
Painless.
What else? Okay, how do you decide the adequacy of sclerotomy?
Sir,
That you have done enough?
we have to go to the
Subcutaneous level, we have to enter.
subcutaneous level, sir.
That's why. Okay, that's it. That's the level. But how do you know that you have done enough, or you need to make some more incision?
There should be adequate expansion underneath, sir. We should be able to.
Expansion and popping off of a fat
Subcutaneous tissue.
will be there.
The incision which you gave, how do you have maximum benefit of sclerotomy incision? A straight incision or a lazy incision? Whatever you choose, you have to say. You have to choose. You have to say why. Straight or lazy?
Sir, straight incision.
Straight incisions is what we. Yeah.
How do you substantiate your statement?
In straight incision, the release, we can make out the release of tissue.
And in lazy it won't happen. Okay. And how do you feel the adequacy of or judge the adequacy of tangential excision? When do you stop?
When there is punctate bleed, we are able to see the punctate bleeding, then we can stop the excision of the burn tissue.
Suppose in this case of a chest burn involving also, which instrument will you use for tangential excision?
We use a what?
Will you use an Humbee's knife?
Yes, sir.
Will you have any difficulty in doing that using Humbee's knife?
Sir, the depth will be
Sir, especially in the chest, there is contour problem. So the Humvee's knife cannot be used. We can proceed with the
The time is over,
over
sir.
there.
Yes.
And
yes.
other areas, abdomen, we can do a tangential excision.
Correct. Thank you. Okay.
Now moving to the second spotter. I would like to request Lakshmi ma'am, same Ramakant Bembes, to be the lead.
Diagnosis. Team 1. What is the diagnosis?
It's a great.
What is the diagnosis in this case? Burns.
Post-burn.
Treated for burns.
Ma'am, this is a status post excisional release and neck contracture release, and SSG has been done over the neck, ma'am, over the right side of the neck, with the hypertrophic scar at the level of sternum.
Post-burn scar. Contraction of the neck. Great.
Is it your diagnosis? That's all? Team 2,
With residual
any
post-burn
correct
scar
diagnosis? No. It is competition. You should be very careful. Diagnosis is one question and you have to answer properly. Team 2. Team 2, any
Team two,
improvement you want to do?
Ma'am, it is a post-burn sequelae with hypertrophic scar over the lateral aspect of the right side of the neck, with hypopigmented patch over the anterior aspect of the upper chest, and also
Yes,
linear band is there
that
over the
is
lateral
the
aspect of the
thing
right.
I expected. So you will get the point. Team 1. So what is the problem the patient will be facing in daily life with this type of post-burn sequelae? Team 1. What problem the patient daily life? Don't think only functional aspect. Okay. So what the problem the patient will be having? He is a manual laborer or farmer.
If he is a laborer, he will be having difficulty in day-to-day activities to perform whenever he wants to
I
extend
told
his.
you it is not just a functional.
In aesthetically, his appearance, the appearance of the hypertrophic scar is also.
Ma'am, appearance is objectively morbid, and also there will be pruritus over these scars.
No,
and
yes, okay.
And also functionally, there will be some moderate degree of restriction in the activity.
Not functionally. With this type of patient, why they come to us? Team 1. Why the patient come to us?
The patient usually have urticaria or itching over the scar, which.
If he comes to a private hospital, both teams, anybody can answer.
For scar management.
What scar management?
The anxiety scar, the anxiety appearance of the scar.
So there's a hypertrophic scar, ma'am. But he can come for a hypertrophic
which
scar.
will be more bothering for the patient, hypertrophic scar or hypopigmented
The
patch?
hypopigmented scar.
Hypopigmented patch.
Yes. Okay. So everybody will be asking the patient, what is this? Why happened? What will you like that? The social problem is more bothering because there is no restricted movement of the neck or anything, and hypertrophic scar is not very thick or troubling the patient also. Maybe that is something, but the everybody who sees the patient, the person will be asking, okay, can you get rid of it like that? So that will be more bothering for the patient, right? So then. Sir, Ramakant, sir, anything you want to ask initial part before going to management?
I think that's all.
Okay.
Yeah.
So what is the, how will you address this condition? His main problem is the hypopigmented patch.
Ma'am, we advise a patient for we advise a patient for direct sun exposure, ma'am. Avoid direct.
It is already 2 years old. 2 years old. What is the cause for this type of hypopigmentation?
This is due to the
What is the
immature.
cause for hypopigmentation patch in this scar? Team 2?
Ma'am, the scar can be hyper or hypopigmented. Sometimes when the dermal appendages get damaged, this can, or when the melanocytes get damaged, this can happen.
Yeah. Okay. Yes. Again, coming to the management aspect. Team 1.
Ma'am,
How will
whether we can go
is
ahead with
the
a
patient came to you?
scar excision and resurfacing with a split thickness skin graft,
Yes. What type of
or
skin graft you use? Can you
we
excise
can
totally or do anything? Excision means what type of excision you do?
you will excise the whole scar, madam.
Full thickness scar you excise.
Yes, ma'am.
Yes, ma'am.
Full
Full
thickness.
What
thickness
about
scar we
team
will
2?
excise.
Team 2?
Ma'am, we have to do intralesional scar excision.
Means what does it mean by intralesional scar excision?
We have to keep within the scar tissue, ma'am. We should not go into the normal tissue.
So you will excise full thickness.
Yes, ma'am.
Both want to do that?
Not we don't.
Any other modalities, team 1? Leave about the excision, we'll tell later.
Can give laser treatment.
Laser.
Laser therapy.
Laser for what?
For the hypopigmented scars.
Will you give to the hypopigmented scar, team 2?
No.
No, ma'am. In hypopigmented scars,
What else you will you can advise? Who is telling what? Which team?
We can use tissue expanders in this case, ma'am. Or we can do melanocyte transfer or tissue expander.
Okay. So get excision or tangential excision. Even for scar, you can do tangential excision and resurface with which type of skin graft?
Ultra thin grafts.
What about team 1? If you don't answer first, you don't get the marks. You are not understanding. Team 1 first answer for the first 3 spotters.
Thin skin grafts.
Okay, thin skin graft, right? So Ramakant sir, will you tell about melanocyte transfer?
Yeah. Melanocyte transplant, non-cultured melanocyte transplant is one of the modality for this hypopigmented scars. But there are variable this recovery in such cases. Some cases respond very well with natural pigmentation in such cases. In some cases, you will not get pigmentation because these cases melanocyte may not work in this scar because of the vascularity issue of the scar. But you should keep in mind that that is one of the option, melanocyte transplant. Can team 1 describe about the melanocyte transplant procedure? Team 1? Hello?
Sir,
yes. If you know, you tell, okay, otherwise. Team 2?
No, ma'am.
Okay. Sir, you can tell a few steps of that.
Yeah, it is a very simple procedure. It is you can do it in your own OT on the in the corner, just like a lab. It requires a simple incubator and a centrifuge. First thing, you have to take a ultra thin graft, skin graft, ultra thin, very thin graft. So it should be transparent. The graft should be transparent. Then it is made into small pieces with scissor, and trypsination is done. That is the first step, trypsinization, and that is kept in the incubator for 1 hour. After trypsination, you can tease out the this melanocyte and this keratinocyte from the dermis, and dermis portion you can just filter out, and you can keep the keratinocyte and melanocyte suspension. And in that suspension, you can add this plasma of the same patient, autologous plasma of the patient, equal quantity. Generally, 15 to 20 ml blood sample is sufficient in this type of patch, which is in this picture. And after that, putting the plasma, it is centrifuge. And after centrifugation, you will see a small disc of dark melanocyte and keratinocyte mixture suspension. You should discard the superficial, the upper part of that liquid from the test tube and take out the bottom dark suspension. And that suspension, when it is ready, you should do the dermabrasion or tangential. In this case, tangential excision. In case of leukoderma or vitiligo, we do dermabrasion. But in such burn scars, we have to do tangential excision of the scar, and you have to spread this suspension, melanocyte suspension, and you cover it with a dry collagen. So this is how melanocyte transplant procedure is done.
Thank you, sir.
Yeah.
Moderator, Seema ma'am, you can ask a few questions.
I would like to ask about the excision part again. So the hypopigmented scar, you said you will excise, tangentially excise. So you have removed very thin part of the scar. What happens to, because there is also, the scar tissue beneath, which will be little, sort of disturbing for the patient, because this will pull and push, and, patient will still get, they will say that, okay, after operation, the color has come out. What can you do to reduce that, to reduce the contracting segments in such a case?
Post-operative
No,
scar
during
massaging.
operation. During operation.
We can do fishtailing around the borders, ma'am.
That is one part. That is
yes.
one. Here, not much of fishtailing. It's a sort of a white scar.
Darting questions.
Yeah.
Darting
So
incisions.
what else? So that you release the, the tension, the pull in the scar, which will be there even after you do all these things that you have mentioned. So what can you do to help the patient? Or team 2 can answer?
The fishtailing obviously can be done in order to release the tension, and also
okay.
while covering, we can use a dermal substitute as well, and cover it over the skin.
I would like to hear something more. Not covering during operation. You give few cuts to the scar.
Yes. Break the scar tissue.
Break the scar tissue, and you can check the points where the tension is more. Break it there. Few cuts within that, and then when the tension from all sides is released, then you can put whatever you want to, dermal substitute or skin graft, whatever. That will also give relief to the patient. This is a very small thing, most often forgotten, but this is a very important thing that the patient will get benefit out of it. Okay, thank you.
Very valid point. Practical point, ma'am. Even I do that.
Yes.
So after a scar release in the center also we have to do. Yes.
Yes.
I invite the judges and senior faculty. Dr. Venkatatnam, sir.
Nothing particular. Go ahead.
Dr. Bhattacharya, sir.
You mentioned about tissue expansion. Do you think you'll get more benefit by tissue expansion than any other method?
Team 1.
Tissue expansion. Sir, yes, sir. By doing tissue expansion, we can retain the normal tissue, and we can excise the scar tissue.
Where will you put
and
it?
replace
How many expander will you put, and where will you put?
Sir, one expander, we can put it on the opposite side of the supraclavicular region, sir.
Supraclavicular region. So what will you do? How will you get the advantage of opposite side supraclavicular expanded skin to come to this? You will waste a lot of skin, no? Expanded skin.
You have to keep the tissue expander, which can be advanced into your defect. So where will you
chest wall, inferior chest wall?
Clinical photo.
Say again.
Rohit,
inferior side of the scar, sir, over the chest wall.
Rohit, place the photo. Go to photo.
So,
yes.
Now you tell.
Sir,
inferior surface of the scar, sir, over the chest wall.
Surface of the scar, we can put it.
Only one expander will be enough.
Two expanders.
Sir.
So where will we put the second one?
One over the opposite chest, we can.
Superior and inferior, sir. Superior, we can place one expander. Superior side of the scar over the neck, sir, beneath the platysma, and inferiorly we can place beneath the scar over the chest wall, sir.
You talked about skin appendages. What are skin appendages?
Skin appendages are pilosebaceous units and sweat glands.
Sweat glands. Hair follicles.
What else? What else?
Hair follicles.
What else? You talked about intralesional excision. That means a sort of serial excision.
Yes.
Isn't it? So serial excision depends upon what? The benefit of serial excision depends on what?
presence of dermal.
While doing serial excision, some of the dermal component we can retain it back, sir, such that the graft that we are putting will take up, and
Suppose you
the vascularization will be.
It depends upon the laxity and advancement of the adjacent area, isn't it?
Surrounding tissue.
Yes.
This is a
Surrounding
scarred
tissue.
area, badly scarred area. Will
Yes.
you get benefit of the serial excision or interlational excision? Very minimum, isn't it? Suppose you have to do it for a nevus in a fresh area, you will get much more benefit.
Sir,
Yes.
their intention of telling intralesional excision is a keloid. So they wanted to excise the scar and resurface with the graft, not the serial excision, sir.
So then it is okay.
Yeah,
I mean,
they are telling that like that.
because otherwise you won't get the benefit of advancement.
sir.
And second thing is, you mentioned about dermoabrasion. Do you think dermoabrasion will be useful in this? What is the principle of dermoabrasion? In this sort of scar, will you use dermoabrasion? If at all you do it, if at all you want to do it, how will it benefit?
Dermabrasion.
What is the
usually removes the
yeah?
It helps in resurfacing of the unsightly scars, sir. The collagen, when we do the dermabrasion, the collagen will be replaced, sir.
What is the limitation of the depth of dermabrasion? Then you'll be able to answer this. If you know that, then you will be able to answer. Suppose for any scar, you want
Yes,
to do a
sir.
dermabrasion.
Yes.
What is the limitation beyond which you should not go? Otherwise, you will produce a what scar?
Sorry to interrupt, sir. Time.
Beyond epidermis, we shouldn't till the depth of epidermis. We should go, sir.
Papillary dermis.
Till papillary
So
dermis.
here it is much more deeper, so not useful.
Yes.
Thank you.
So that is the reason tangential excision and grafting is the best and affordable method for this case. I'll show the photos also in next session. Okay.
Yes.
Yeah.
Next photo, ma'am.
Yeah.
I would like to request Dr. Ravikumar Chitorius.
I would
Manish
like to
Singhal, sir,
announce
to be
Dr. Manish Singhal sir could not join. In his place, Shashank sir will join and conduct the session. Dr. Shashank sir is available? Dr. Shashank Chauhan. Dr. Venkatratnam sir, will you join for discussion of this case, sir?
Okay.
Dr. Ravikumar Chitoriya sir and Dr. Venkatratnam sir will
Where is Ravi? Ravi?
join.
Ravi is there?
Yes, sir. He is there.
Yes, yes.
Okay, so question to team 1. What do you see in this image?
Sir, this is an image showing hyperbaric oxygen therapy machine, sir.
Why you said that?
this is an enclosed chamber.
Enclosed chamber with where a patient is kept inside with 100% of oxygen for a period of over 30 minutes. This helps in increase in the blood supply to the wound.
Don't tell the function. Justify
Sir,
that. Don't
sir.
tell the function. I'm asking you why you said this is a hyperbaric cell.
Why it is
So there is a pressure chamber the pressure valve kept outside. We can see it to monitor the pressure, and we can see the pressure monitor outside with readings, and completely enclosed chamber which.
Can you listen? Just wait. Can you
Sir,
listen?
your audio voice is breaking, sir, and
Am
low,
I
very low,
I'm audible?
very
Am I
low
audible?
volume.
More closer to the phone. Microphone.
Am I audible?
No, not yet.
Okay.
You are faintly audible.
Okay, now am I audible
Yes,
now?
yes, yes,
Yeah.
sir. Yes. It
Am
is
I
good.
audible now, sir?
Yes, sir.
Okay. So you said it is a hyperbaric chamber. I
Yes,
said this is not hyperbaric chamber. Justify it.
Sir, we can see there are the pressure valve.
No, I'm telling you this is a Topox chamber. What is Topox chamber? Okay, this same question can be asked by the other team also, or we will.
You can.
No. If other team can answer.
Okay, other team, can you
Team two?
justify that it is a hyperbaric chamber? He said it is a hyperbaric. I said it is not hyperbaric. Justify it. Why it is not a Topox chamber than SBOT chamber? Second team, can you hear question?
Yes, sir.
Okay, so madam, both the teams are not able to answer this
Answer,
question?
sir. You can tell, sir. You can answer
Okay.
the question.
Should I give the
Yes,
answers
sir.
now only, or
Yes,
should I give the answer in the
Yes.
end?
Sir, you can finish because again, recollecting the questions is difficult.
Okay.
You just
So please, both the team remember the basic difference between the Topox chamber and hyperbaric chamber is in the hyperbaric chamber, the entire body should be inside the chamber. Whereas in the Topox chamber, the entire body is not chamber. So it is called a pseudo hyperbaric chamber called Topox chamber, in which the lower limb or that particular hand is kept in the chamber. So, madam, the answer is given. Should I
Okay,
ask the
sir.
next question? Should
Yes,
I ask
sir.
the next question?
Yes, yes, yes.
Go ahead.
Okay, though, who discovered the first hyperbaric oxygen chamber? Team 1? Team 2? Madam, both are not able to answer. Should I answer?
Yes,
Go
sir.
ahead.
Okay,
Yes, sir,
it was the British clergyman with the name called Henshaw. Please note down Henshaw, because you get a theory question also. You must write with the small basic definition and history. Henshaw, British clergyman Henshaw. Should I go to next question, madam?
Yes, sir.
Yeah.
Yes, sir.
Okay, what was the name given to the first hyperbaric oxygen chamber? What was the name given? Team 1? Team 2? Both are not able to answer, madam. They should not Google it. So the answer is domicilium. Please note down both the team. The first chamber name was given domicilium. Should I ask next question, madam?
Yeah.
Yes, sir. Yes, sir.
Okay,
Sir,
next
you can
fourth question.
proceed, sir.
No, I am going because it's like a quiz. It should not
Yes,
become a
it is good.
discussion.
It is
No,
good,
no,
sir.
go ahead. Go
because
ahead.
No, no,
Whatever you
Limited
because-
time, so you need not ask me. You can go ahead
No, because you must note down the points now. Who is answering, not answering. It's a quiz.
because they are not answering, sir.
So next question is, what is the Steel Ball Hospital? Team 1? Steel Ball Hospital. Okay, team 2? What is Steel Ball Hospital? Madam, both are not able to answer.
Sir,
Go ahead.
please, sir.
So the Steel Ball Hospital was made in 1928 with the six-story building with a diameter of 64 square meter. So they thought if we can make not the chamber, the entire building can be pressurized. So it became defamed, but yes, it was effective. And that was the first concept in the beginning when they started, and they gave the name Steel Ball Hospital. My next question to the first team is, what is the unit which you give hyperbaric oxygen? What is the unit we use? Like we have a dose, na? Liter, milliliter, deciliter. So what unit do we use?
1.5 atom to
1.5. I did not ask dose. I am asking unit. What is the name of the unit? Team 2. Team 2.
Atmospheric pressure.
No. It is ATA.
ATA.
What is the full form of ATA?
atmosphere's absolutes.
Atmosphere, sir.
Okay, madam. So one team has at least given the full name. They were not knowing the unit, but they were knowing the full
Name.
of the unit.
Okay. Okay.
So should I go to next question?
Yes, yes, yes.
Yeah.
Please note down the who is answering and who is not answering.
Yes, sir. I'm
Okay,
noting
again, unit team 1. Team 1. So what is the basic difference between mono chamber and multi chamber? Don't talk about the multi means more room, more people. Don't say that. Tell me this scientifically. What is the basic difference between a mono chamber and a multi chamber?
Only single person.
Again, I told you, don't talk about the number of people. Team 2.
No, sir. They nodded their head now.
So remember, in the mono chamber only oxygen is allowed, whereas in the multi chamber 2 other gas can be applied. So next question is, what are the other 2 gases which can be combined? Team 1. Okay, team 2. Madam, both are not able to answer. So the other 2 gases which can be combined is helium and nitrogen. Note down, helium and nitrogen. Okay, so if you are giving a next question to team 1, if you are giving a treatment in multi chamber, so what should be monitor of the other people? Suppose there is an attendant allowed or there is a nurse allowed. So what we should monitor of the attendant?
They shouldn't open the
No, don't tell me the
chamber.
precaution. What we should monitor of the attendant?
The arterial blood gas levels.
Wrong. You need to team 2. Common sense.
GCS.
Common sense.
GCS.
Pardon?
GCS.
Wrong. Madam, both are wrong. It should be nitrogen level, because in multi chamber we are giving 2 other gas. I said common sense, helium and nitrogen. So nitrogen can be calculated of the attendant because he's unnecessarily taking nitrogen. Oxygen is okay for. Is it okay? Understood? Should I ask next question?
Yes, sir. Yes, sir.
Name 3 laws which are used in hyperbaric therapy. Name 3 laws. Unit team 1.
Pascal's.
Wrong. You said Pascal. Okay. Pascal. You said Pascal, but it is wrong. Okay, so please don't give negative marking. Team 2.
Boyle's
No
law.
negative marking,
Boyle's
sir.
laws.
Okay, if you are saying Boyle's law, you are giving 1/3 answer. Other 2 laws.
Charles.
Okay, so I will give you answer. These are the 3 laws. Please note down which are used in the
Dalton's
application of
Dalton's.
HPT. Pardon? Okay, please don't waste time. Let us go to fast quiz. It's a quiz. So the
Dalton's
answer
law,
is,
sir.
huh?
Dalton's law, sir.
Wrong. If you tell wrong answer, no guess. Then you are telling cow is a buffalo. It means you don't know buffalo also, cow also. Better say I don't know. If you are telling 4 lakh person is a cow, but actually I'm asking buffalo. So color is different. Milk both are giving. So please be careful. No negative marking. Just say I don't know. So the law, please note down the 3 law. Henry law, Charles law, and Boyle law. One team said 1 law, at least Charles law and Boyle law. Which law is more important of the 3? Next question. Team 1.
Boyle's law.
Wrong. Team 2.
Charles law.
Wrong.
Henry's
Team 2.
Henry's law.
So why you said Henry law? Because they said no. I intentionally said no.
Sir,
Henry's
sir,
law.
applicability in burns also you
Okay, burns.
few
If you are
questions
giving,
related to that.
Okay, if you are giving in the for burn patient, when you will start hyperbaric therapy in burn patient?
After the initial resuscitation period, sir. After the initial resuscitation, when the patient is hemodynamically stable.
What is the definition of initial resuscitation in burn? Initial
20
resuscitation can last up to 24 hours
24 to
also. It can be
24 to
6 hours.
48.
No, the
Initial
moment, please listen. The moment urine output becomes optimal, you say the resuscitation is optimally adequate. So I'm asking you, it can be adequate at 2 hours also, 6 hours also, 24 hours also, because up to 48 hours you are trying to resuscitate the patient, depending upon when the patient has reported and how much the deficit of the fluid was. So answer, you correctly tell what time you will start.
After 72 hours.
Wrong. Team 2. Team 2. Madam, both are not able to answer, even if the
24 hours.
No,
After-
not after. Within 24 hours, please. Because the hypoxia will cause more eschar formation, more damage, more inhalation burn. Even the IV fluid can be given inside. Even the ventilator can be taken inside. Even the parameters can be taken inside. So please remember, when it comes to the burn patient and hyperbaric has to be given, it should be given as early as possible. Don't worry about resuscitation. 24-hour resuscitation is simply IV fluid. That's all. And oxygen. So anyhow, you are giving oxygen. Okay, so next, other moderator wants to ask question, or should I keep on asking question?
Go ahead.
One
Go ahead.
indication in burns to give hyperbaric is what?
Inhalation burn, sir. Carbon monoxide poisoning.
Okay.
Any other indications?
Indications, ma'am. Superficial burns, ma'am. 2nd degree superficial burns.
What all you want, you tell.
The 2nd degree superficial burns, which if we give hyperbaric oxygen therapy, the healing rate of the wounds will be sooner.
Increase.
Should I ask more question?
Go ahead.
Sir, if anything improvement of the answer you can do, and then go ahead for next, sir.
No, because nowadays everybody is having hyperbaric therapy. They should know the dose. So I'm asking you the timing of the therapy in burns. I'm asking the dose of the, and what are the basic indications and contraindications. Can you tell me absolute contraindication? Absolute contraindication.
Pneumothorax.
Team one.
Pneumothorax.
Pneumothorax, sir.
Which team is answering?
Team
The first
one,
team.
sir. Team 1 is answering, sir.
Absolute contraindication is pneumothorax.
Sir is muted. Ravi sir,
Sir, unmute yourself.
Okay, the dose is 2 to 2.4 ATA for 90 minutes. Please note down, because you must know the indication, you must know the timing, you must know the dose, you must know the contraindications, and of course, finally, you should know the complication. What are the complications of HBOT in burns?
Sir, barotrauma.
Okay, barotrauma. Yes, barotrauma is one team has answered, madam.
Yes, sir. Yes, sir.
Okay, next question. If you are giving the HbO2 to the burn patient, which part of the oxygen is increasing in the blood? You are increasing the oxygen, na?
Yes,
So
sir.
which part of the oxygen is increasing in the blood? What are the 2 components of the oxygen in the blood? Other team? Other team?
Oxygen carrying capacity of hemoglobin.
No, not carrying capacity. There are two components, bound component and the free component. You should say, so which component will increase?
Free component is increasing.
Free
Yes.
component will increase.
Okay, good. So this team has answered. It is the free component which will increase and not the bound component. So don't worry about the anemia. Even if there is anemia, don't worry about anemia. We should give to increase anemia. You must give the hyperbaric therapy. Other moderator can ask question.
No, go ahead.
Time is up. Rekha ma'am, you would like to ask, or shall I ask sir to continue? Seema ma'am. Dr. Seema ma'am. Seema Rekha Devi ma'am.
Yeah.
Moderator, would you like to add anything, or shall I continue?
Yeah, not about hyperbaric again, but just care of the skin graft after it is grafted. I would like
No, ma'am. Only related to spotter only.
Okay.
So
No,
you would like to ask any questions?
No questions.
Okay, I'm asking you.
Senior or judges. Anybody would like to contribute or ask questions? Otherwise, Ravi sir will continue.
Let the rapid fire continue.
Okay, sir. Ravi.
Okay,
continue.
Okay, please team note down in case you have done early tangential excision and you have done grafting and then you are taking the patient for hyperbaric also. Okay, or sometime in an electrical burn you have done early even flap because something vital structures are exposed. So what is the mechanism? What is the mechanism that the flap will not fail or failing flap will improve? What is the mechanism? Team 1.
Sir, there will be increased vascularity to the tissues.
Wrong. Next team.
Negative
Team 2.
suction.
Pardon?
The negative pressure.
No. What is the problem in the flap? Why it is failing? It is a hypoxia. So
Yes.
how
That is
hypoxia?
increased oxygen delivery.
So how oxygen will improve? Closure of AV shunts. There are AV shunts which are developing because of hypoxia. So once you close, automatically oxygen increasing. Note down. It is the closure of AV shunts which are opening because as a compensatory mechanism. So they get closed, oxygen increases. And when you increase the oxygen, automatically a failing flap becomes. So what is the protocol to be followed in case you have done early flap and it is troubling you in a burn patient? What is the dose difference in a case of early flap versus a classical HBOT therapy? What is the difference? Dose.
We'll double the dose.
What do you mean by double?
The pressure, double the pressure. Usually we give
wrong.
1.5 to 2.
It is never the dose which it doubles. Never.
Duration will
doubles.
increase it. Sir.
Frequency. Please note down. It is the frequency. It is increased to BD. Same day you are giving 2 times, and then subsequently converted into OD. And then how many sessions you will give?
Up to 6 to 7 days.
Wrong. Don't stop up to 20 sessions. Why? Because again the flap will go into failure mode. Otherwise, classically, how many sessions are given in a hyperbaric oxygen therapy?
24 to 30 sessions.
Yeah, minimum 30 sessions. So it is a very, very long therapy. It's like so here you have to give it up to 20 in a flap,
20,
not 30.
Yes.
Is it clear? Is it clear?
Yes.
Okay, madam, over to others in case they want to ask.
Ravi, can you tilt the camera? We are only seeing 40% of your face.
Sir was in
Now it is better. Now it is better.
I am holding the mobile in my hand. I am in the hospital. I am holding the mobile in the hand, so my hand is falling down.
Okay. Go ahead.
Okay.
Scientific.
If you allow, can we move to the team 2, sir? Spotter session.
Yeah, go ahead.
Okay, sir, sure. Team 2, your first spotter. I would like to request Lakshmi ma'am and Mani Singhal to lead.
Dr. Mani Singhal is not there.
No,
He's there.
Join in between.
He's there.
Oh, yeah, welcome, sir.
Hi.
He's there in full form.
So, fine. So, team
1.
Team 1
You
will
ask
answer.
questions, sir.
Okay. So, what do you think? What day of burns can this patient be? And how do you decide that? So, this is the picture. I know it is not a perfect question to ask, but maybe you can little zoom and tell me what day it can be and why. This burns can be between day 3 to day 7, sir. And it is because there is a decrease in edema and the burns is not that moist to look as it will be in the initial acute stage. And this is a mixed degree burns where superficial burns is more compared to deep. And the deep burns is present on the medial aspect of arm, mid-arm, and over the over the anterior axillary fold, sir.
So, okay, ma'am. So I think we will ask from the next team now.
No, sir. All questions first, team one
Okay.
only.
Okay.
If they don't answer, we'll go to team two. If
Okay.
you are not satisfied with the answer, you can tell the answer,
Fine.
sir.
So why don't you think that it is J20 or something?
Sir? Sorry?
Why don't you think it is J20 or something?
Sir, the zones of injury are very clear, sir. The zones are very clear. There is no granulation tissue or there is no sloughing of the wound, sir.
Okay. Fine, ma'am. Fine, ma'am. We can.
Yes,
we
you are
have
right.
You are right. So what do we do now? We have another question from the second team, ma'am, if you don't mind.
Not second team, sir. All questions will be first to first team only.
Okay. So now we'll ask. Okay. So can you see the cannula on the right elbow?
Yes, sir.
So is it the correct cannula to resuscitate burns, or do we use something else?
We use a wide bore cannula, sir. This is a green colored cannula. We use a wide bore cannula to resuscitate, sir.
Okay. So this is also okay, or another should be a little better as per the.
Yeah, two wide bore cannulas would be better to
Team
resuscitate.
one.
Two wide bore cannulas.
Two wide bore
resuscitation.
Okay.
Team one.
Team one. Any improvement?
We can use. We can access the line two wide bore cannulas in the leg, ma'am, because legs are free.
Or we can go for a central venous catheterization.
Okay. So do you put central venous catheterization in emergency, or you want to do it in the emergency resuscitation?
In emergency resuscitation, it can be done as a part of resuscitation if higher percentage is there.
Team two should answer first. Allow them, give the opportunity. If they don't answer, then only team one has to answer.
So central venous central and catheterization can be done, sir, in the initial phase.
In this case?
In this case, yes, sir. Because he'll be going through multiple procedures and long anesthesia and everything, sir. I would prefer to put a central line catheter. Femoral preparation.
I don't agree with your answer. My question is very clear. For emergency resuscitation in major burns, will you have a cannula to the local IV access, or you will go for a central line? You will go get a regional access, or you will go for a central line. So central line is not the correct method to do resuscitation.
So we can use an arterial line, sir.
Have you ever seen an arterial line for resuscitation?
No, sir. No.
I don't.
Sir, nowadays the critical care people, anesthesia people are available. If available, it can be used for venous monitoring purpose also. So we cannot deny that central line need not be done. So it is one more thought.
I will not get into that discussion if the question is
yes,
we cannot deny that, but it is not the method of choice.
If you are supposed to put wide bore cannula, as sir said, but anesthetist available and condition, you can go for it also. Okay.
In case of shock, especially burn shock, arterial line is not a good option. Okay, and that is mainly for monitoring. And any other access? What about interosseous access?
Yes, sir. In pediatric patient, we can use interosseous access, sir.
So interosseous access you can use. Have you ever seen interosseous access?
Yes, sir. We have seen them.
Okay.
Which one is used?
Tibia is used.
Yes.
Which part of tibia?
Anterior, sir, near the shin of tibia.
Pardon?
Anteriorly near the shin of tibia, sir. Just near shin.
Right. So you can use an interosseous access also in children. Okay. So now about the facial burns, how do you manage inhalation burns? Do you do any chest X-ray for inhalation burns?
Sir, chest X-ray is actually done initially, but parenchymal injury cannot be.
Question is very clear. Do you do for inhalation burns? Do you need chest X-ray or not to diagnose?
No.
Or
No, sir.
Not for diagnosis.
Correct.
Inconclusive.
Parenchymal injury later on. It is
Later on we'll.
Okay. So whenever there is an inhalation burns, what type of injury occurs in the lower airway and why?
Sir, in the lower.
In the flame burns with inhalation component.
Yes, sir. Sir, actually there'll be loss of surfactant, so because of which there can be atelectasis of the alveoli, and
do you have any heat injury in the lower airway? Yes or no?
Sir, if in steam
because of the
inhalation,
heated air, do you have any heat injury in the lower airway or not?
in steam injury or in blast injury, it is expected.
It is not. Why?
Because the cooling effect of the heat gets dissipated in the upper airway only, sir.
Why? You are right. Why? Why the heat is dissipated in the upper airway?
Because of
because of the. Ma'am, should I ask the other team or we have to give?
Yeah.
Go ahead.
Ask the team one. Team one.
The upper airway, the mucus present in the upper airway, it absorbs the heat. It is not transmitted to the lower airway.
You're right, not transmitted, but not because of mucus. Just because of circulation.
Convection.
The high circulation.
Convection.
High circulation, it is does not dissipate. So the lower airway does not have a heat injury typically.
Yes, sir.
Okay. Fine. Ma'am, you want to ask anything? Over to you, ma'am.
You finished your question, sir? Or anything
I
you
can
want to
ask anything.
like to ask about the wound management?
Yes, we can. Wound
Next,
management
that
will-
is your turn.
Okay.
Pardon?
So if the initial part of resuscitation taken care, by seeing these different types of wounds, so if you are asked what is the pathology, Jones, who described the Jones of burn wound?
Jackson.
So can you make out anything in this that sort?
There are 3 zones, ma'am. Like the zone of coagulation, the zone of stasis, and then the zone of hyperemia can be seen in a few regions here.
Yes. So which zone will transmit and will have some dynamicity, and how it will?
The zone of stasis is a zone which is a dynamic zone, and the factors that influence the zone of stasis are infection, edema, hypoxia, hypoperfusion.
So can you convert this with what precautions?
We have to do adequate resuscitation and give adequate oxygenation, prevent infection. With early wound care, we can prevent the zone of stasis being converted into a zone of coagulation.
Yes. So how will you manage this wound? It's how much TBSA you feel? What is the TBSA and how will you address it?
Yeah.
Clinical photo, please.
Clinical photo, please.
4.5 plus. 18 plus.
Approximately tell first.
Less than 25% burns.
So
20%
how will you
burns.
address this? How will you address it?
Ma'am, first, wound management. Wound management, we have to do early tangential excision and cover, ma'am.
When will you plan it?
No, we have to plan it once the patient is resuscitated and stable, ma'am.
So you know
within-
that percentage, how much time it will take? When will you do it?
Yes, ma'am. For
So-
the superficial burns, for 2nd degree superficial burns, we can do.
Will you take it for tangential excision or not? You have seen this case.
Yes,
It's
ma'am.
in front
I
of
would
you.
not. I would not like to take it to tangential excision, ma'am, as most of the part of the burns appears to be superficial, and I would actually go for a more conservative management with collagen application, ma'am.
Collagen application. So you will
Yes, ma'am.
wait and watch for the deep wounds to recover.
No.
So what is the best treatment you can give for the patient? You can plan it because it's less than 20% you are telling. Do you think the resuscitation will be required for 1 week?
No.
Huh?
Early excision and grafting would be a better choice.
So you have to assess and take it up, isn't it?
Yes,
ma'am.
Why
Yes,
you are going towards the tangential excision, early excision in burn patients instead of conservative treatment?
Yeah.
Earlier was the dictum to treat for 3 weeks and then go for interventions. Now we are more towards the early excisions and all.
Yeah,
What
it
is
is
the
a-
reason?
Yes, ma'am. The reason being is like if the deeper wounds are not addressed, the zone of stasis can be converted into hyperemia, ma'am. So that is why
Yes,
the
yes.
deeper wounds have to be addressed, and the deeper, deep 2nd degree burns and full thickness burns have to be tangentially excised and
Why?
covered because
What
the scar
benefit it
for
will give?
yes, ma'am.
To
Because
prevent infections.
these wounds will take more than 3 weeks.
Yes,
to
nidus for
heal.
infection, you have to remove that.
Yes.
Next,
Yes, ma'am.
what
It-
other things?
Scar formation is bad in these wounds, ma'am.
Next,
Team
team 1.
Conversion of the superficial burns into deep burns
The overall
can be prevented.
hospital stay will be decreased.
Yes, good. Yes,
And,
in general, you have to think all the things. Yes, hospital
And
stay
that is a
decreases.
definitive
What
management
else?
for the patient.
Pardon?
And early rehabilitation can be started for the patient.
Yes.
This is a single stage procedure. Once the graft has taken up well, the patient can be discharged early, ma'am, and started for rehabilitation if after the early excision and the graft has taken up well.
So partly both the teams shared this question answer, but I would like to tell the advantages of early excisions in the low percentage burns also, like salvageable burns. So one is you are removing the nidus for infection and you are removing the tissue which is responsible for the release of the toxins into the systemic circulation and chemical mediators, induced seeds. Okay. And third one, you are avoiding the workload on the health personnel. Okay. So doctors, sisters, all these people should do the teamwork. So once you remove that nidus and resurface with the skin graft available, either autograft, allograft, or skin substitutes. So it is like a one-time treatment you are giving for the salvageable burns. So it is decreasing the workload on the personnel, health personnel also, and decreasing the pain to the patient, suffering to the patient, morbidity, mortality related to the SIRS and the MODS. Even you see, so low percentage burns dying because of these things. Okay. If the patient is fit and low percentage burns of second degree or the third degree, take up for early excisions. So in the resurface with available autograft, allograft, or any skin substitutes, and give relief to them so that the work burden decreases, hospital stay decreases, expenditure also decreases, and recovery is fast, rehabilitation is fast. So these are the very advantages. That is the reason we are shifting to the early excisions than to the conservative method of treatment. Okay. So that what we expect from the PGs, you have to understand, right? I think the time is over, isn't it?
Yes,
moderator.
Let moderator ask.
Moderator, Dr. Seema
Yes.
ma'am.
Yes. Can we go to the picture, physical picture of the patient? Yes. Here, as you have said, partly it is second degree superficial and partly second degree deep. Which part did you say? It is the second degree deep part is the upper arm middle part.
Yes, ma'am.
And the chest part is mostly superficial with patchy. There are some.
Yes, ma'am.
So can you do, both the treatment in the same patient, like one only with the conservative management and number two is with tangential excision?
Team two.
Yeah.
Yeah.
Ma'am,
Okay.
there is a technique of enzymatic debriding. Enzymatic debridation can be done.
No, I'm not coming to enzymatic debridation.
No,
just
no, ma'am is asking a part
Yeah.
which is superficial, will do
Just
conservatively
conservative
and
management.
Yes.
Yeah. And
excision.
partly you are going to do tangential excision.
Yes,
So
we
which are the
can.
parts and why? Why you have chosen those parts?
Like,
Upper arm you want to do tangential excision. Why?
yes,
Why?
but that deep
Two
second
important
degree.
points. Can you sort of say 2 points why you want to do tangential excision in the upper arm? 2 points in favor of your answer.
Yes, ma'am. The reason being that I want to remove the necrotic dead tissue. So that is why I want to remove all the dead and necrotic tissue which are present in the wound.
Okay.
Burn tissue.
Number one,
And-
it is second degree deep mostly, and
Yes,
these are prone to
These are prone to infection and prolonged wound
Trophy.
healing and conversion of
most
Or scar.
hypertrophic scars, they
And
are in the second degree deep burn. So that is number one valid point that you want to excise and graft it as early as possible. Number two valid point, can you say the number two valid point?
Ma'am, to prevent sepsis and moths.
That is okay. But no, just look at the picture there and tell me one valid point. That's why observation is very important. Can anyone say? Team two, no?
Team one.
Ma'am, for neck part, we can go for early excision grafting, ma'am, since deep burns are.
I'm still with the.
Sorry, sir. Madam is asking about arm.
The axillary part appears to be deep
Contracture
burn.
can be prevented to prevent contracture, axillary contracture.
Very good. And this is, you see, anterior axillary fold contracture
Fold is
is quite
involved.
common in such type of
Yes.
burn.
Yes, ma'am.
And if you just go on doing conservative management, the scar will, gradually develop into, hypertrophy
Into a
and
contracture.
contracture. It's bound to happen. You want to excise it and graft it and start early mobilization.
Rehabilitation, yes, ma'am.
Thereby, rehabilitation. Thereby, you can prevent,
The contracture, yes, ma'am.
in the axilla. At the same time, the arm wound is going to heal. Correct?
Yes, ma'am.
Yes, ma'am.
And one more point I would like to tell you that the parts which are deep second degree, that you can do the selectively mark with the marking ink and excise, and a whole area you can cover with the collagen. Okay, or the areas which are you have done the tangential excision with the graft, and rest of the areas collagen. Okay, you should select your treatment for depending upon the depth.
Exactly.
Right?
So you should observe the patient, very minutely and decide what is your treatment that, can help the patient. Very small points. And the axilla contraction is also very small, but you should not miss your diagnosis.
Especially in lower percentage, you have to select the treatment according to the depth of the wound. Sir, Bhattacharya, sir.
Can you tell me why both the forearms are typically spared? Hands are burned. chest is burned, arm is burned, but forearms are free. Why?
Team 2.
Would you
Immediate,
like
sir,
to?
I think,
Yeah.
sir, I think in this type of, maybe it's a flame burn, and when he caught fire, probably he folded his elbow, so that's why the forearms are spared.
Any other possibility?
He was wearing garments, sir. So the place where he's wearing garments had more deeper wounds, and the place where there is no.
Which is that garment which is only worn in the forearm and not in the chest and arm and hand? Is there any such garment?
No,
At least not for men, I think. Will you ask anything relevant in the history of the mode of injury?
Yes.
Yes.
Yes, sir.
What is it?
Electrical flame burn.
Yes. And how does it happen?
It's an arc injury, sir.
Yes.
So
So you must explore that area. That the history is so important in
Please
this
answer, sir.
in this particular. And second thing is, will you splint the axilla while resuscitation is going on?
Yes, sir.
Yes, sir. We would like to splint the
Why?
axilla.
Why?
Because we don't want the contracture to develop later on. So we would like to splint the axilla, and we're using an aeroplane splint.
Another practical question is, when you are planning as a clinician and a specialist, we will do tangential excision here and conservative there. Okay. How will you convince the patient for tangential excision? Because most of the patient will say, sir, please do the dressing and heal me. I am fine. I don't want to get operated. This is the common experience of each one of us.
Practical problem.
Now you tell me, how will you convince that tangential excision is needed?
Sir, we would say the duration of, I would convince by telling the duration of treatment that is required, sir. If in case we have done a wound excision, tangential excision, and grafting, the wounds can be healed within 3 weeks, and early rehabilitation can be done. So he can go to his work very early. But in fact, if we had to wait for like regular dressings, he might not rehabilitate or go back to his occupation very early.
But then the patient will say, madam, you are going to take skin graft also. That is all, you are creating another wound for me.
Yes,
and you are telling within 2 weeks it will heal. So what will happen to the donor side?
So the donor side will heal, but the donor side also will heal in 2 weeks, sir. So
no, it
the
doesn't.
donor side morbidity will
it doesn't.
also.
It takes more than that. So your calculation, I'm asking your calculation, how to convince the patient for tangential.
What else you can tell conservative treatment means?
This is very practical.
Yes, sir. And cost effectiveness also, we can explain to the patient about the cost effectiveness that it's a single.
It will be very difficult to calculate cost effectiveness because this is surgery. Okay. And
we would also tell him that regarding the sequelae that will follow if we don't do the tangential excision.
Yes.
Also the problems that he is going to face in the future, and the amount of the surgery that will be required for that.
I'm telling you, it's extremely difficult to convince in this particular patient for tangential excision, because he will say, I will require blood. He said, I have no attendant. He will say, this is an operation which will be cost effective, may not be cost effective. And then you are producing another wound on the thigh and so on. So it won't be easy. For extensive burn, it may be for life-saving, etc. But for this type of burn, it is extremely difficult to convince these patients. So you have to be very methodical in your approach. Yeah.
Can we move to the second?
Yes, ma'am.
You should tell.
You have to formulate. You have to have full
Yes.
questionnaires and full answers, positive answers to convince him. So you should make a very nice chart before talking to the patient. That what are the advantage, disadvantage, and time taken, cost, everything. Then only he'll be able to convince. Otherwise, he will run away. He will say, somebody will tell me that he will dress and heal, and he's not bothered about axillary contracture. He'll say, okay, if
the
it
main
happens.
What he has to face during the course in sequence, you have to explain and
voice
show
is
the
echoing.
photographs also, because the same amount of blood is procedures. Oh, okay. Then we'll go for the next. I think.
Wait. Lakshmi. Can I add 2 more points?
Yeah, sure, sir. Previous, Rohit. Previous.
Okay. Team 2. Did you hear of stasis?
Yes, sir.
Tell me how it is relevant in this case, in burns.
Sir, this the zone of stasis is in burns, sir. Like it's a dynamic area where that zone is in. The 50% of the cells are dead, dead, and 50% cells are viable. And this zone is in a zone of vasoconstriction, sir. But by giving adequate resuscitation and by taking care of the burn wound, we can.
Who said 50-50? Where is it given?
Most.
I am asking about the zone. I am not asking about the percentage.
Yes.
It is microcirculation.
Yes.
Team 1.
It is big,
Team 1.
because it is highly influenced by the toxins, which are released from the zone of
Only toxin.
this
Inflammatory
toxins and inflammatory mediators and cytokines.
Who said that?
Team 1.
Team 1. Team 1 gets the point. The point is the heat in the microcirculation. The size of the vessels is up to 10 micrometers. Okay, microns. So in that 10 microns, the blood cells are up to 6 or 7 microns size. So in that, the heat from the surface comes down and then it coagulates. Then stasis occurs. Then what happens is immediately the body sends its own mechanisms, chemicals to constrict them. That further adds to the damage. So the stasis is very important. So you should target in the initial treatment itself to minimize the period of stasis. Why? As you said, it goes down and down, and that means deeper and deeper. So the zone of stasis is very, very important. You must be very clear about the mechanism and how and why it happens and how to prevent it or minimize it. Number 1. Number 2. Next question is, what happened to the hands? Bhattacharya sir only brought the hands part. Both the teams did not mention about it. Now, what is happening to the hands and why they are like that? Can they be prevented? Or now what we will do?
Sir,
Team 2.
Team 2.
Management of electrical burn, management of burns in hand, sir. We have to prevent edema. We have to prevent. We have to give adequate splinting, and we have to do adequate rehabilitation and exercises.
I asked why it is allowed like this. You are on the way, but not correct answer.
Why the hands? These are the
Why
joints.
it is allowed to become so edematous? Why both the hands?
Because he's been not given proper elevation, I think, sir.
Exactly.
Post-operative period.
Yes.
That's why it's edematous.
Basic principle in the limb treatment is splintage, elevation, and followed by the physiotherapy while in the splint itself.
Yes, sir.
So starting from while in the splint itself. So that is not taken care of. If that is not taken care of, what will happen?
He will develop contracture, sir.
Exactly. So the tissue fluid will have got the more proteins, proteinaceases, and then the toxins also. So the patient will get hand stiffness, and by the time you need rehabilitation, you finish upper thing, the lower things will be stiff. They will not be useful. So you have to take the whole picture into consideration and attend to every part. Over.
For the information, that photo is taken on within 24 hours. Okay, for the sake of taking photo, the hands are kept like that for the clear vision. Okay, so it was taken up for the tangential excision and collagen coverage. We didn't do any graph. So the results will be shown later. Okay, coming to the spotter number 2.
That is a good explanation.
Yes.
Okay.
Not good explanations are really. I am behind my thesis to take proper photos of the patients after cleaning the wounds for the sake of Plastiquest.
One must be able to guess also. Okay, go ahead.
Yeah, spotter 2. Dr. Ravikumar Chutiria, sir.
Okay,
and Dr.
team 1.
Team 2, sir. Team 2,
Okay.
team 2.
Okay, team 2. Team 2.
Yes,
What
sir.
do you see in these pictures?
Yes, sir. So it's a post-burn sequelae, sir, with severe contracture of the wrist joint, and there is extension of the MCP joints and flexion of IP joints of all the fingers, and there is also.
I am not asking the components of the sequelae. I am asking you, can you tell what is it called? You should say post-burn deformity. Correct? And
Which
that
side?
deformity.
Which part?
Sir, point is given to them.
Okay, so that is why
They
I'm
told
asking.
the post-burn sequelae and started describing the components.
Okay, so what is the name you will give this to sequelae? Sequelae can be ulcer also, non-healing ulcer also.
Yeah, you tell that.
So tell me the name of the sequelae.
What is it?
Flexion contracture of the wrist joint, sir.
Only flexion contracture?
Flexure contraction of the wrist joint and with the extension of the MCP joint with the flexion contracture of the IP joints of all the fingers.
And there is also dislocation.
And also there is a hypopigmented patch over the dorsum and volar aspect of the distal forearm as well.
Please, one by one, because there are many findings in this photograph. So you have said there is a flexion at the wrist, and then you said hyperextension at the MP, and then you said hyperflexion at the eyepiece, and then you
Yes,
said
yes.
there is a flexion deformity at the thumb, like that you should go, and then in between someone said dislocation. Now, who said that dislocation? You have not examined the patient. You have not examined the patient. You have not seen the
X-ray is not
X-ray.
there. Good comment.
So how you have told this dislocation word? You have not examined, you have not checked the movement. See, if your shoulder get dislocated, you have to ask the patient to do some movement to say whether it is subluxated or dislocated. Okay, second question. What is the difference between subluxation and dislocation?
Definition you tell.
Yes. In dislocation, the whole joint is completely out, sir, out of the articular surface. But in subluxation,
You're
it is
answering?
only partially.
Slow. I can't hear loudly.
So in subluxation, the joint is partially displaced from its articular surface, sir. In dislocation, the articular complete the joint is completely.
So how much is partial? How much is partial? You should not use subjective. Seeing the X-ray, fluxated, you say dislocated, because that will decide the deformity. Sir, madam, they have not answered this note down quiz. So if the 40% of the joints, pardon? If 40% of the joint is in contact with each other, then it is up to that you.
50%.
Sir, your voice is breaking,
50%.
sir.
Less than 50% is subluxation and greater than 50%
But
is
it's
dislocation.
more than 100%. Is it audible? So I have given the answer, madam.
Sir,
It is 40%, not 50, 40%. Am I audible?
It is interrupted, sir.
Okay, next question. Am I audible?
Yes, now audible.
Okay. So the first question was the name the deformity, and second question was what is the difference between subluxation and dislocation, and the third question is name the deformity at thumb. What is the name of the deformity at thumb?
The name. In this type of
I ask team 2, another team.
Specific name. Team 2. Team 1.
Other team, please name the name of the
the
deformity at thumb. Post-bun deformity
They answered,
at thumb.
They answered, sir. Team 1.
Z deformity of the thumb.
Called Z deformity. Z for zebra. Z deformity. Usually it happens at the thumb.
Next question.
Okay, so I should not give answer?
Sir, they told Z deformity.
Okay, I could not hear. So next question. Okay, now when
team 2. Sir, your audio again not.
The grading, McCoy grading of deformity, hand deformity. Can you tell me the grading?
Yes, sir. Initially,
McCoy deformity grading.
So grade 1 only tightness is there, sir, but there is no functional impairment. And in grade 2, there is functional impairment, but there is no restriction in daily activity. In grade 3, there is restriction also in daily activity of the patient. And in grade 5, it is severe deformity, sir. Grade 4.
So it is the word which we use is in the first grade you say only word tightness. Second grade you use word architecture.
Yes,
architecture is still intact. Then third grade you say it is starting deviating from the normal architecture. And fourth it is totally gone. And then what is the further grading of grade 3 and 4?
A and B, sir. A, B, and C.
Subgrading of 3 and 4?
A, B, and C, sir. A is flexion contracture, B is extension contracture, and C is flexion as well as extension both.
Okay, correct answer. This is they have given correct answer. Okay, next question. Next question is suppose this patient hemoglobin is 3.5 or 5 and patient is not fit for even regional anesthesia, block anesthesia. Then what you will do?
Sir, suppose the patient is not fit for anesthesia and his hemoglobin is very less, so we can't consider taking him for surgery. So initially, like we can go serial stretching exercises, sir, with splinting.
Okay, so you said serial splintage. So when you do serial splintage and when you do non-serial splintage, do you think this patient is fit for serial splintage when there is so much deformity? Do you think this patient will be fit for serial splintage? The joint deformity. Usually serial splintage should be given, maintain the deformity, but you cannot improve the deformity. Please understand.
Yes, sir.
You cannot improve the deformity. You can maintain it. So I am asking you how to improve the deformity.
Sir,
There is a pull and
What is-
push. To break the contracture, we can use pull and push technique, and we can even use traction. We can use traction, sir.
Okay. And what is just assisted traction or distraction? What is the just? What is the full form of just? Next question.
JESS.
What is the full form of just?
Joshi's external.
Correct.
Joshi's external.
Okay, other team can answer. What is the full form of just?
Stabilization.
Okay, madam,
Joshi's
both are
external
both.
skeletal
right.
stabilization.
You're
Both
right.
these-
Joshi's external
Yes,
skeletal
sir.
stabilization.
Okay, so now you said Joshi external stabilization system. It will stabilize. It is not going to improve. What is the other way of putting just? You should say just distraction. Now, when you convert a fixation into distraction, you understand? You should say just distraction system. Now, just is a only stabilization system, but you can pass the pins and start putting the distraction. So what will happen? Each joint angle will change, and the elastic tissue will also start lengthening slowly. So you should say I will put, because Guande also has a limitation. Guande is also to only maintain, hardly it will, because the amount of force required for an elastic tissue to break, you know how much force is required?
10 to 15 pounds.
Very heavy, very heavy. So you need really something which is working at the level of joints or tendons. So you need a just distraction assisted. So what you do, you immediately put the just system, and now you put the distraction system. Ask the patient to move 0.25 millimeter a day, not every day, till the patient is able to tolerate, so that the scar should not break down. And even if you achieve 2 millimeter, 3 millimeter, by the time you are transfusing the blood to build up the patient. And next question, while distracting with the just in a severe deformity, if it breaks down, ulcer breakdown, what you will do?
You will wait till the ulcer heals.
No. Don't wait for ulcer, because then it will be more severe deformity will develop, more severe hypertrophy will develop. In that case, you have to cover it immediately. And what is the Gillis principle? What you should cover? Like with like.
Like with like.
So here, what will be breaking? Epidermis, dermis. Tendon will not break. Tendon will not break.
Epidermis
it
and
will be the
dermis will be
epidermis, dermis, and the subcutaneous tissue, and maybe even the fascia also will not break. So in that case, you have to put immediately a graft.
Yes, sir. Grafting has to be done to cover the wound.
Mentally prepared. What? At least camp. What is camp? Next question. What is camp? Other team can answer. What is camp?
The length of the collateral ligament.
Wrong. Please
Go to
don't
team
guess.
one.
If you know, you know. Otherwise, we'll carry to the next question. Madam, should I
Go to
answer
team
or
one.
should I?
Team one.
Question we
Pass on
couldn't.
to next team.
Question, sir, we couldn't understand.
We couldn't hear the questions.
Okay, I am again
They want the
repeating.
question to be repeated.
yes.
What is camp?
Team two,
CAMP.
team two.
What is camp?
Team 2 now.
Team 1.
Okay. So
Team one?
Now team 1.
Wrong.
If they don't know, please if you don't know, just tell no.
No,
Sir,
they don't know, madam. This is wrong.
Yes,
Wrong.
sir.
Say pass.
Okay, pass. Question is pass.
Sir, you have to answer. Both teams told no.
Then I will give you answer. C means cellular. A means acellular. M means matrix. P means products. Can you name one CAM product?
C means cellular, E means.
You know the answer, otherwise pass it. Don't hold.
Sir, can you camp? C means cellular, E is.
C means cellular, A means acellular, M means matrix, P means product.
BioBrain.
Yes. So anything which is a substitution for the what we used to call biosubstitute or biological substitute. Now it is banned. You should not use. So you should not use word. Substitute. So you should use word scaffold. Scaffold means not single layer like collagen. It has to be minimum 2 layer to 3 layer to 4 layer to 5 layer, and the outer layer has to be the synthetic layer. Do you know scaffold? What is scaffold? Next question. What is scaffold? Other team, what is scaffold? Okay, madam. They are not able to tell.
So it is a tissue. It is used for a tissue engineering, sir. Like 2 to 8 cells will be taking.
No. I'm not asking the mechanism.
And will be
No. Sir is asking definition of scaffold.
What is a scaffold?
It is a biomaterial.
Meaning
Scaffold is a
of the
biomaterial.
scaffold. Team 2 first. Try to answer what is meant by scaffold.
Sir, actually time
If
is
you
over.
don't know, team 1 will answer.
Okay, they are telling time is over. Now, madam, over to the other.
Team 1. Team 1.
Scaffold, it is actually a biomaterial which provides a base structure for the cells to grow and into a functional tissue.
So scaffold is a infrastructure which is applied over the site, which allows the site to get ready. Like your building is made now. When the building is constructed, they put pipes, wooden, and that is called scaffold. And the scaffold is removed when the building is ready. So here, what will be the scaffold? Here the scaffold will be the multiple layers of the biomaterial. So what are the classification of scaffold? Next question.
Synthetic.
One team at a time.
It is natural and synthetic, sir. Synthetic can be acellular and cellular, which are bioengineered.
So there are two types of the method. As you said, one is cellular and one is acellular. And one is synthetic. See, please understand, cellular, acellular, and synthetic. Okay. Then before you put the scaffold, what you will do? What engineers they do before putting the scaffold? So what you will do? What is the prerequisite before you put the scaffold?
Make the wound bed ready. Depride.
No, if you just put the scaffold, it is not going to work. There has to be some regeneration allowed. You don't allow the body, humanity is not going to regenerate, it's not going to heal, it's not going to get ready wound bed. So you have to add regenerative technique. So it becomes regenerative scaffold. Please understand. Before putting the scaffold, the engineers are putting some cement, they are putting some material so that the solidification is better. So here what we put in the plastic surgery, here we put the regenerative. So do you know some regenerative material or technique before you put the scaffold?
Sir, sorry to interrupt.
Rohit, wait for a few minutes. Rohit, wait for a few minutes. Go ahead.
Let this question to be answered.
Growth factors like epidermal growth factors and insulin-like growth factors and platelet-derived growth factors.
So one, madam, she is right. Some growth factor has to be put. And what are the source of growth factor? You said epidermal derived, platelet derived. Very good, madam. She is correctly answering. You can give the marks to her.
Team 2.
Yeah, please note down. She has answered that we must put some regenerative agent before we put the scaffold. Otherwise, that scaffold will go waste. Okay. Should I ask more question, madam?
No, sir.
Just
no,
one or two.
Moderator questions are there. So I think after completing.
Okay. Moderator, madam.
Seema, madam, would you like to ask any questions?
Hello. Yes.
Would you like to ask any questions, madam?
Yeah, I wanted to ask you about what will be your approach to such patient? Surgical or non-surgical? How will you approach this patient?
Since it is a severe flexion contracture of the wrist and involving the whole hand, so I would actually proceed with doing a surgical release, contracture release. And
sorry, first, what would you do?
The first wrist contracture will be released, ma'am. And
so tell me whether you are going to do. There are so many contractures almost at each joint.
Rohit, clinical photo, please.
Yeah, are you going to do all at the same time, or you want to stage your procedure?
Wrist will be considered first, ma'am, in a first stage, and wrist contracture will be released, and then the immediate coverage will be given for the created wound, and then after rehabilitation of this, then I would go for the release of other contractures involving the MCP joint and the fingers, ma'am.
Just a second. I mean, you said, okay, I take it as you will be releasing the wrist first.
Yes, ma'am.
But then, do you think that you will be able to release it totally? Can you release it totally in one go?
I think.
How much do you expect to? Because you must know, what you're going to achieve with the release. That's too bad a contracture involving all the joints and subluxation, dislocation. So if we're focusing on the wrist, how much do you expect that you'll be able to do in the first stage? And after that, suppose you cannot do, all at one go. What will you do, to get at, reasonably good level, at least, if not dorsiflexion, at least, plantar. So at least that much, otherwise this will be functionless, the wrist will be. So how much do you want to achieve And then what will you do to the patient? Very practical point.
We would consider releasing it up to 30 to 40% of the wrist contracture, and especially considering first on the radial side, so that the patient can the contracture will be more towards the functional position, and then we would cover the wound with skin graft, and then we splint the wound.
Second question. You said you'll be releasing 30-40% whatsoever.
Yes, ma'am.
There, do you think that you'll be able to put a graft only?
No, ma'am. We can also go for a flap.
Because all the tendons, it is,
Yeah. If the tendons are exposed, we can consider for a flap.
It's going to be exposed.
Yes, ma'am. If it is going to be exposed, then we'll consider putting a flap, or else we can even put a dermal substitute and graft it.
But then suppose you put a flap that to make keep the wrist in that position, you need to do something else.
Yes, ma'am. We need to fix the wrist using KYs.
Yes. So it should tell all the points, because it's not easy, just you release it and just go for second sitting, or serially you have to release it. You have to give a cover. You have to give a cover, and then you have to maintain that position, and probably you will be able to do a little more with physiotherapy and all, a little more to make it at least plantigrade, if not dorsiflex. Okay, from that position into bring into that at least that plantigrade. So you need to keep that position after releasing. You have to fix it in that position. Yeah, then only when it is achieved, then you go for second stage.
Yes,
okay, agree?
Yes,
okay.
Any questions from judges or senior faculty? If there are no questions, can I move to third spotter, ma'am?
Can I ask a question?
Yes, sir. Yes, sir. Okay.
Yeah. Jess came in the picture, and Joshi splint. So, can you tell me who was Joshi and what was his full name? Where he belonged to? In which specialty he is? Any idea?
Sir, Joshi sir is a orthopedician.
Right.
And he belongs to West Bengal.
No.
No, sir. Then I don't know.
BB. Okay. He is Dr. B.D. Joshi. He is from Mumbai. He is an orthopedician. You must know the contribution by the Indians. Number two is in continuity with Dr. Sima Rekha. When if you see that picture, even the distal forearm is also depigmented. That means it's all deep. And how will you release the wrist in that case? What will you keep in mind? Just an incision across the bolus aspect of wrist will do the job.
Can I see the picture again, please?
Can you see the picture? You can. Yeah. Just one release, horizontal release will be sufficient.
Sir, not volar aspect incision completely. Over the thumb also there is the radial aspect of thumb is also
okay.
Attached.
What I'm asking is just one release is enough. Just one incision is enough.
I think one incision would be sufficient, sir.
So what are the structures which will be exposed?
Sir, flexor tendons can be exposed.
Flexor tendons, maybe neurovascular bundle, etc.
Yes,
okay, everything will be exposed just in front of you. Yes, but the flexor tendons will be also adhered to the distal forearm scar. So if that remains adhered, yes, and you do a release, do you expect that adhered tendon to give good function to the wrist or distal to it?
So we can achieve a good function of those flexor tendons which were attached to the scar after release. We can consider doing a flap.
No, I'm not asking that. Yes, two aspects I'm asking. One is, will you make one single incision to release it, or you excise the scar thinking that you will be able to give a flap cover? This is one. And number two is, what will be the condition of those flexor tendons? We are only talking about tendons.
We can give a.
They are also flexed. Yes. They are contracted.
If I would prefer to give one more midline incision, sir. Exactly in the middle.
Okay, you can give one more incision, or you can excise the whole scar. That's okay. But underlying tendons, what are you going to do? They are exposed and contracted.
Tenolysis, sir. Tenolysis.
Tenolysis may not give the full answer. Anything else you would like to do?
Tenolysis with fractional lengthening.
How will you lengthen?
At the junction of the muscular tendinous junction.
What will you do there?
There we have to cut the tendinous parts, fractional length.
Cut or what will you do to lengthen?
There are plastic surgeon.
Routinely used procedure.
XY.
So many hints.
Z-plasty to the
Z-plasty to the.
How will you do sutureless Z-plasty? Any idea?
Sir, proximal tendon will come over the distal tendon. We give a Z incision and we overlap the approximated one above the other. We suture.
So you give a Z incision and stretch it. So the two ends come nearer to each other.
Nearer
Okay.
to each other.
But
Yes,
even then, we have to suture now, sir.
Yes, at that point you have to suture again.
Yes.
That's a weak point.
Yes.
But the tendons will be exposed, and there is no scope for flap graft in this
Give
case,
cover.
Yes, sir.
isn't it?
Flap has to be put.
What
Definite
type of
flap.
in this hand position? What type of flap will you prefer?
Abdominal flaps.
Abdominal
Abdominal
flap.
flap. That's our question. Abdominal flap.
Abdominal flap. Why not groin flap?
Sir, abdominal flap will be more easy for the hand positioning.
Any other reason? Why not groin flap?
Hair bearing.
The
Hair bearing area, sir.
No. You see the position of the hand.
It's a volar contracture, so abdominal flap would be better, sir. For the positioning.
Alternatively,
Monitoring.
either abdominal flap or
We can do
Free flap.
Free flap.
pedicle flap.
yes. Why not free flap? Yes, certainly. Yes. And what will be your sequence? That means first wrist, after that
First wrist, and then we
thumb.
can release the thumb, and then the rest of the fingers.
rest of the fingers in one go.
Yes,
Yes.
MCP joint.
MCP joint
MCP joint.
first,
IP
and
joint.
then IP joints.
Okay.
I would like to request Ramakant Bembe sir and Ravikumar sir to
Yeah.
lead questions.
So, what will be your diagnosis of this burns wound case?
So non-healing chronic burn
Yeah, what is the definition of non-healing wound or chronic wound?
with wound which don't heal within 3 months.
Can other team tell me the correct
More than 3
definition?
weeks. More than 3 weeks, if it is not healing, it is considered chronic wound.
Can somebody tell about the rate of healing which defines the non-healing wounds?
Less than
Healing
1 mm per
through
less than 1
heat.
mm less than 1 mm per day, sir, rate of healing. Less
When
than
the-
point.
Yeah, the
0.5.
correct definition is, I will tell you, suboptimal healing rates occurs when wound area decreases less than 10% area over a period of 2 weeks. That is 14 days, less than 10%. And what is arrested wound healing or refractory wound? Have you heard of this term?
Yes, sir.
Sir.
So with like failed treatments, sir, these ones don't heal even with multiple attempts of wound healing. They don't heal. Failed treatments will explain.
You are
the
partly
refractory.
correct. Yeah, you are partly correct. What is the duration when you label it as arrested or refractory wound?
1 year.
6. Sorry, I didn't. It is 6 months actually. It is 6 months. So how will you go? How will we investigate and how will you manage this case?
So first, when we get this case in the board, and we would like to send the investigations with routine investigations, and then also we would like to do a tissue swab culture sensitivity and look out for the possible reason for why the wound is not healing, and if we found any sensitivity for any bacteria, and we follow the antibiotic protocol and antibiotic cover, proper antibiotic cover, and then we would like to take him up for surgery and debride the wound. And I would not like to.
I will interrupt here. Just sorry to interrupt. First, we will talk about investigation. You talk about taking the tissue swab. Is
Yes,
there
sir.
any better method of knowing the organisms correctly?
Tissue biopsy.
Tissue biopsy.
Yeah, correct. How the tissue biopsy should be taken in such wound?
Multiple tissue biopsy should be taken.
No. Tell me how we'll go ahead with the tissue biopsy, the procedure.
How will you take?
We should
How
not
much?
take the SCHAR. We should
Huh?
not take the SCHAR or sub-SCHAR correction. Or we should actually first give
This
a
wound,
wash.
there is no ishkar in
Yes,
this wound.
we have
In
to
this
give
wound.
a wash,
Uh-huh.
wash the wound, and then take the biopsy from the.
Can other team tell the correct way of
So,
taking biopsy?
we can go for edge wedge biopsy.
Puncture biopsy, sorry.
Edge wedge biopsy we can go,
No,
sir.
no. I will tell you the correct way is scrap the granulation tissue and take the biopsy from the base of the wound. That is the correct way to know the organisms. Okay. And so
How
coming
much
to
tissue? How much tissue
3
you have
grams.
to send?
Yeah.
3 grams.
Minimum
3 grams.
So you got the biopsy report now. So how will you go ahead with the treatment?
How will you analyze?
What is the peculiarity of this wound? Immediately you can tell. How is the surface and what you label this?
There is a biofilm over the
Yeah,
wound,
yeah,
sir.
yeah. Perfect. Yeah, that was. What is biofilm, by the way? What is the definition of biofilm?
The biofilm is an exudate with colonized organisms, sir.
Mm-hmm. Can the other team tell me the correct
With
definition?
which
Yeah, go ahead.
it's a exudate with the colonized organisms, which will prevent anything, sir. Like it will prevent any antibiotic or anything to penetrate the wound, sir. Or
Other team can tell the definition, correct definition.
Biofilm is a self-produced polymeric substance which is produced by the bacteria or fungi, which is adherent to in which the microorganisms themselves are adherent.
Yeah, perfect. That is called EPS, extra extracellular polymeric substance, EPS, produced by the bacteria, and they are in multiple organisms are there, maybe bacteria, fungi, viruses. That is the peculiarity of biofilm. So, coming to the team 2, tell me the management.
we can do debridement. We have to do debridement here, sir. So the debridement we can do VersaJet debridement.
That is a tool, but what should be the right way of debridement?
Sir, we can use a Watson's knife and tangentially excise it.
Yeah, perfect. There has to be radical debridement of the all granulation tissue. It should be sharp debridement and removal of all the organisms. Then
after we get a good bleeding, we can debride it and give a proper wound wash and dressing. And then I would not like to. I would go for a. I would want to relook this wound later for any other progression in the infection. And then if everything is okay and granulating after proper antibiotic coverage, then I would cover this wound using a split thickness skin grafting.
What are the agents which are used to prevent the recurrence of biofilm? Anti-biofilm agents.
Sir, povidone iodine topical agent can be.
No, it is not povidone iodine. Something different iodine.
Sir, cedoximir.
Cedoximir. Yeah. And what else? Other molecules?
Sir, acetic acid can be used, incorporated in the dressing plan, and vinegar can be used.
Can the other team tell me the other agents which are known?
Argotil AG, anything based on AG, silver based.
Silver. Yeah. There is a thing available, silver stream. That is a silver nitrate solution. That is a good anti-biofilm, this thing. Then catoximir, you said. Then there are PHMB solutions available. PHMB solutions like Maxocil or Prontoson. Prontoson is recently not available, but Maxocil is available. That is a good agent to prevent recurrence of biofilm, which is very, very common. Yeah. Then that is a very important part of preventing recurrence of biofilm.
Recurrence, yes, sir.
Yeah. Then what will do?
Then after multiple, we would like to observe the wound over quite a few days so that we don't get the recurrence. And once we are through with it, we would like to cover the wound with a split thickness skin grafting.
Yeah.
And the most important part in this wound, I think there is a knee joint, popliteal contracture also. So I would like to give a good splint.
Yeah. And what are any newer modalities which are used till the wound is ready for the graft? You are debrided. And then
after debriding, I think we can also use VAC therapy. We can give a VAC therapy for this patient.
Perfect. Yeah. VAC with instillation therapy will be better in biofilm.
Yes, sir. VAC with instillation therapy.
There you can use these agents as an instillant. Yeah. Perfect. Ravi, you can ask your questions. Dr. Ravi.
You said which team is this?
Team 2, sir.
Team 2.
But because it is written biofilm, so you said biofilm, huh?
No, sir. I could see the shiny layer, and also it's a slimy layer which can be seen, sir.
So it is by seen or by feeling?
You can see it on the dressing.
Never say by see. It is always by feeling. Like when you are walking in the rain, there is a sliminess and you slip. So by look, you will not be able to assess. But when you fell down, you realize, oh, there was a biofilm on the floor. So exactly here, although they have written biofilm, you should say clinically, I will, while doing the examination, when I feel it with the gloves, I feel very slimy. Although granulation tissue will always be slimy, but there is a too much of sliminess. And if there is a change in the color, usually it is a whitish in color, but it can be of varied color. So here you are saying biofilm. That is why on examination, although they have told you there is a biofilm, it means they have examined. You have not examined. So you should say because it is written, sir. I don't know. So when you are saying biofilm, then as you have rightly described the definition, then what is core run sensing?
Sir?
What is core run sensing? Other team? Other team? Okay, madam, should I answer?
They don't answer, you answer, sir, no problem.
Okay, core run sensing is a mechanism which is produced by the biofilm itself. So what they do, they keep on multiplying, and they break down, and it goes into the blood circulation. So typically you will see it is multiplying. So from one A point, it will go to the B point, B to C. So they sense each other. They are very clever. So it is like an umbrella opened in the rain. So when the umbrella is open, whatever antimicrobial agent you put, it is not going to attack you have to break this umbrella. So they make a core run sensing as the mechanism to make a shield. You understand, both of you team?
Yes, sir.
So how to break this biofilm? What are the techniques?
Excision. Excision, sir.
Excision. So as simple as you should say mechanical, chemical,
Yes.
mechanical, chemical, and
Biological.
Pharmacological.
wrong. Mechanical, chemical,
Enzymatic.
Enzymatic.
Yes, that already you have told to
Enzymatic.
Dr. Bemde. Yes, you have told the matrix degeneration, matrix enzyme degradation therapy.
Yes.
So by chance somebody has already scraped it mechanically by a gauge piece. If you simply scrape gently by a gauge piece, dry gauge piece, so what will happen? Biofilm will come on the gauze, and you can feel the sliminess on your gauze. Now still there is a doubt whether the biofilm is there or not. How you will confirm? How you will confirm?
The tissue biopsy.
Wrong. It cannot be biopsies. It can be MRI. 50 micron thickness will be seen in the MRI. So you have to ask your radiologist, please go to the that much thin. The way they see the wall of the vessels, they see the sheet of the nerve. So you have to ask, please focus on the where all places the biofilm is there. So clinically it is a slimy layer, but confirmed by MRI. Any other method of confirming? Fluorescence technique.
Fluorescence.
So this is only for theoretical purpose, but practically it is not possible. So you have said mechanically treatment, you have said chemical treatment, and then is there any other treatment? You said enzymatic treatment. Any other treatment? What is PDT? Other team, what is PDT? Okay, I will answer. Photodynamic therapy. Photodynamic therapy. Okay, and in the in the chemical agent which you have told silver, you have told other agents, but they are all detrimental to the normal cell. Can you tell me anti-biofilm agent which is not detrimental to the normal cell and it treat the
Nexabird. Nexabird, sir.
Pardon?
Nexabird.
No, please don't use company name. I'm asking what is the agent?
Bromelain derivatives.
That is only enzyme. Even the bromelain also damages the normal cell. You don't want to damage red, na? There is a normal cell also.
Sir, silver nanoparticles, sir.
Silver also damages the normal cell. Silver, betadine, the peroxide, all cells. See, remember what you will not put in your eyes. Don't put it on the wound. Will you put peroxide in your eyes? Will you put betadine in your eyes? Then how can you put something on the wound? So I am asking you physiological water. What is physiological water? Pardon?
Normal saline, sir.
That is not antimicrobial. Antimicrobial agent which is physiological water.
Sir.
Normal saline has no antimicrobial activity. Why you are saying normal saline? Other team?
Water.
Other team? Madam, they are not able to answer.
Yeah, give
Okay.
answer, sir.
Okay. So physiological water means like normal saline, the pH should be neutral. Our body needs a neutral pH. So then it will not damage the normal cell. Whereas betadine, silver or any agent you take, they are having some either alkaline nature or they are in acidic mode. We need a neutral pH. So superoxidized solution. Superoxidized solution are called physiological water. Why? Because they are neutral pH and they have a antibacterial, antifungal, antiviral, antisporicidal, antimycobacterial, anti-HIV. Please go through the spectrum and antibiofilm. Very, very important. So it is a neutral, it kills the biofilm, but at the same time, it will remove the biofilm. You don't have to go. Otherwise, is there any other method of biofilm removal other than chemical or enzyme? Any other method, you know? Any team?
Sir, cauterization,
Please,
cauterization.
UV
please,
light,
cauterization is banned. Cauterization
light,
means current. It will cause
UV
more
light
burn.
exposure.
Wrong.
Sir,
Pardon?
UV light exposure, sir.
Which exposure?
UV light,
No, UV, not UV light.
pulse dyed laser.
No, don't guess. What is crisp CPR? Okay, so gene editing. Gene editing means they will not allow biofilm to start working. That is a higher end method. But that you should know. We are not telling whether in your center it is available or not. You should know. World is doing it, na? Okay, now back to the case.
Sir, time is over. So moderator, we will invite. If they don't have any questions, then we can again proceed, sir.
Okay, madam. Okay.
Seema ma'am, would you like to ask anything? Seema ma'am,
wanted to ask something.
would you like to ask any question?
Yeah. Before that, Dr. Bhattacharya, he asked.
No, you carry on. You please carry on.
After you, madam.
After you.
Okay.
Ladies first.
Moderator first.
Okay. Coming to the management part. So how do you go about it? You have a large raw area with biofilm and then the contracture of the knee. So
Yes,
how you are going to approach?
Ma'am, initially I would take him for wound debridement and scoop the biofilm completely of the wound, and at the same time I would do a contracture release of the knee and give a proper wash and dress the patient off, and I would go for a VAC therapy for him so that the wound granulates. The wound forms really well, and later on also after removal of VAC, I can also observe the wound once more, and then I can give the final coverage after the wound. The wound is satisfied, and we'll consider a split thickness skin graft. And yes, ma'am, split thickness skin graft.
Do you think you have missed something? You have said very beautifully everything, all the points, but you have missed one point.
Dressing, splinting.
That is very important because you are not going to release the knee fully. It's not possible. You remove the biofilm, you dress it properly, and then you have to give a POP and first, and then you may go for splinting and whatever things that you say. This is very important part. You can't just leave it.
Yes, ma'am.
Practical point. Then only you do all other things that you wanted to do, give back or, then do grafting finally. And by the time you do all that, go for all that, by splinting within a week, 10 days, you will get a nice thing.
Release.
Yes, ma'am.
Nice release. So yes, other things are okay. Only add this.
Sir, Bhattacharya, sir.
Would you have prevented this contraction?
Yes, sir.
How?
Contractor rehab by rehabilitation, sir. By taking care of edema, by taking care of like by splinting, rehabilitation, exercise, we could have in the acute phase. So this could have been prevented in various ways, sir. In acute phase, we can do like edema control measures and early physiotherapy. And whereas in the intermediate phase, we can start with the early mobilization with active and passive exercises.
See, what you're talking is a little theoretical. In acute stage, if you start doing physiotherapy, the amount of pain the patient is going to have, and you are stretching it too much.
Yes.
And it has to be, very methodical thinking. Once you know that it is a full thickness burn, deep burn involving a joint, then you have to go more aggressively to reduce the expenditure, time required, etc. Okay. So you must prevent the contracture. You could have prevented the contracture if adequate dressing and splinting was done initially. And at the earliest, you do the skin resurfacing. That's the question. Answer. Number 2 is, if you have to put a SSG, as you planned, that you will do the release first, then again you will keep doing dressing, and then again you will do the resurfacing or back therapy in between. You see, the amount of expenditure, the amount of time taken, why you have chosen this path instead that you release it and do the grafting? Why not? And do the splinting? Why? What is the role of back in between? What are you going to achieve once you're going to release it and put a skin graft in anyway? What is the role of VAC at this stage, after 6 months or so?
So since the biofilm was already formed in this wound, the recurrence of biofilm can be, that's why I don't want to graft this wound, give a final coverage at a single stage.
Now, that means practically telling that whenever there will be a biofilm, you will always go for remove the biofilm and go for VAC therapy and then do the grafting? You want to suggest this treatment always?
Not always, sir. If the wound is satisfactory enough after the first initial debridement, if the wound is satisfactory, I wouldn't even go for a VAC therapy also, sir.
Now, the third question and the last one is that will you put split skin graft on a granulation tissue?
No, sir. Split thickness graft.
Because some
granulation
people
tissue
say
is
that
not
I'll
good, sir.
put a graft, I will not mechanically remove the biofilm or scrape it and remove the
I
granulation.
would scrape out the granulation tissue and then only graft, sir.
In the same sitting, isn't it?
Yes, sir.
Yes. So how do you decide the scraping of the granulation tissue, depending upon the nature of granulation tissue? Because sometimes it's a fresh granulation, sometimes it's a chronic granulation of long duration. So how do you decide that how much you are going to scrape? So one question is definite that you will scrape and put the skin graft. So how do you, how much do you?
Flush with the moon margin, sir.
No, that is okay. But what I'm asking is, how do you decide that your scraping is adequate?
So after the removal of granulation tissue, we get a white layer. So when that appears, I feel that the entire granulation tissue has been removed, excised. It's been
What is that
scraped.
white layer consist of? That white layer consists of
reticular dermis.
Reticular dermis. So the reticular dermis is already gone in burn, isn't it? That's why it is deburred. That's why it is granulating. So reticular dermis is out of question, no?
It's a fibrous
burn
tissue.
wound, it is a dry area.
It's a fibrous tissue, sir. Fibrous tissue, sir.
Yes.
When we scrape it, the punctate bleeding will be appearing.
Yes,
So we
yes.
remove the granulation tissue and we place the graft
Yes.
over the fibrous tissue.
It's purely clinical judgment and your experience. You scrape the granulation. If you culture granulation tissue, almost every granulation tissue will have some sort of bacteria, isn't it, or fungus or a mixture. So it's purely clinical judgment and duration of the granulation tissue. More it is, more it will be thicker. So you have to scrape more to see that there is punctate bleeding. And then you keep a hot sponge for some time, and then otherwise there will be hematoma. And to prevent hematoma under the skin graft, what simple precaution will you take?
We can use topical application of.
To prevent hematoma under a graft.
Proper hemostasis first, sir.
If in spite of hemostasis, capillary bleeding is there, what precaution will you take, which will almost ensure that your graft will take and there won't be any hematoma? Simple,
We'll give
clinical.
a proper meshing to the graft.
Proper compression, sir.
Let
give
the
proper
second
meshing
team
to the-
answer. Let the second team answer.
Simple surgical technique
Pressure,
to
sir,
prevent
compression.
hematoma under the graft.
Compression, sir. Meshing.
Compression, suppose it is in the neck, then you will compress.
Bolster dressing.
That is the last part. I'm not talking about dressing. Surgical part. Simplest. Every day we do it to prevent hematoma under the graft.
Use epinephrine soaked
Meshing.
Meshing. You
Meshing.
perforate the
Meshing.
graft. What is perforation?
They
Not
told, sir.
meshing.
I told, sir. Meshing, I told.
They told, sir.
Okay, done.
Sir, I invite
Anyway,
Bajaj sir to give some remarks and
I
ask some
just
questions.
wanted to add, if you want to reduce your operating time, you can take the graft at the same sitting, for sitting only. Store
Okay,
it, store the graft. No need to operate second time. Say, then you examine the patient, take the dressing, and then you can put it, in the ward itself or in the minor OT, provided the bed is okay. So that is another point that you can reduce the, cost also and the second operation.
Anesthesia.
We do most of the time there. Okay, thank you.
Bajaj sir, I invite Dr. Bajaj sir. Unmute, sir. Sir, unmute. Audio is not there, sir. Yes, sir. Now you can talk.
First of all, compliments to you. It was beautifully done. But my question remains the same, which I put it down in my last, that our things should not be ambiguous. And secondly, questions should be asked in a more better way. Many of our panelists were asking questions as if they were trying to show their intelligence on the young boys and girls. This should not be the picture. Our boys and girls should be able to enjoy the situation. I'm putting it very politely. Nobody should take offense to this, because I personally like that young boys and girls should be encouraged to, rather than discourage and put it down that you don't know this one, this other. By asking questions so much in a way that shows your intelligence rather than the young boys' intelligence, those who can, boys and girls who can. Second thing, in the slide which you showed down into the team 1, where there are nearly full thickness burn involving the chest and the
back
part of the neck, and I think first slide in the first case. Now there are many other questions which are asked irrelevant totally. Now relevance remains there in such extensive burns. How will move around? Now we were asking about the ascarotomy. What type of the ascarotomy is there? Now, I got a straight line or S line. Now, these straight line and S line, they depend upon only on one thing. If you are thinking in terms of whether the wound will after that automatically, or you have to put a graph there so that no contraction should develop. It has got no bearing on the expansion of the graft and other situation. So therefore, this will not give a good answer to the students. Now, again, the type of sclerotomy remain there, whether you put it down to mid-axillary line and then transverse, that depends upon whatever. In this case, they were not so full thickness burn. They were mostly very deep dermal burns. And therefore, the sclerotomy remain partly only in the skin layers only. And therefore, you're only in a very full thickness burns, which is grade 3 burns, where you can see the tight bands around the thing. But in this case, it was not looking like that. And probably you are not knowing on the back is burnt or not burnt. Therefore, asking that question where the boys cannot see the back, this question was irrelevant.
Sir, I already told there is a back burns and they are also deep.
I agree with you. Now, in the deep burn, problem comes down where you can see deep scar, which is very tight.
Yes.
Therefore, in these cases, mostly deep dermal burn, very deep dermal burns are there. Therefore, tightness may not be so much down there. So then no one talked about when the burns are on the neck, the release should be on the neck also.
Yes.
Because that also part by which you can put it down there. Second thing, in this case, we did not talk about there were burns of both the hands. How you will manage. Now, this was a very big question in such a case where these burns on the hands were deep dermal, both hands, in this case. And we did not talk about that. That was necessary for the. Please do not mind my. I'm very. If you mind, then I will just stop it. Then.
No, not at all, sir. We are taking positively only because.
Well, no one asked any question on it, which was very important point. How you will manage hands in a case where you got a major burns on it, and that remains a very good point for the students to know and discuss around. Similarly, the first slide put it down to team 2. The hands burns what someone asked, and no one asked why the hand burns are only on the dorsum of the hand. There were no burns on the volar aspect of the hand, and the burns were confining to the distal portion, proximal portion of the hand only. Now, I'm not though it is my personal thing which I used to tell very often why these things are happening, but I'm not asking these things everyone will know around. But the question is, we should ask the boys. Though the question was asked why the forearm is not burnt, so that now these children should know about what is protective burn, what other type of the burns are there, how these hand burns and facial burns are involved together. So therefore, that is the question which was asked. Now, in this second slide, most of the burns on the chest were of mostly partial thickness or deep partial thickness burn. Only on the deep 3rd-degree burn was on the medial aspect of the right foot and the right arm. That was completely there, which could be. And total burns were less than 25%. And all questions we asked about how we resuscitate the patient. Now, 25% only burn. Resuscitation can be done orally also, many things also. And there was a small cannula was going on. And on this question, we asked why we resuscitate, we will go to Austrias and other thing, which are less than 25% burn. These things are irrelevant. Now, we can ask questions which are related to that. Now, these burns were less than 25%, where resuscitation could be oral also, without IV also. Now, because they have to remember this, a lot of work has been done on this thing. Then coming down to our questions which you are asked on the hyperbaric. Giving hyperbaric is one thing which is controversial. It is not totally accepted. Hyperbaric oxygen leads to the completely constriction of the capillary circulation, while at the same time you enjoy all benefits by dissolved oxygen in the plasma. This is the only two. There is no free oxygen word is there. It's a dissolved oxygen in the plasma and the oxygen which is going through the RBCs. Now, in all these cases of hyperbaric oxygen, that what goes down, it is dissolved oxygen into the plasma, by which more oxygen can be given. Majority of the time, it has got no role to play in the case of initial aspect of the burn, unless some specific conditions are there. Rest all are controversial. Third thing, we kept on asking the young boys and girls, when the first was started, who started this thing, where this thing was started. Now, these are comparatively unimportant questions, which has got no practical importance other than what the boy has read and other things, which is very important aspect. But these things completely demoralize the boys, but which has got practically no meaning. Now, coming down to finally, the slide which was shown about the very bad hand contracture. Now, this should not be put it down to the young boys and girls, because this was a very difficult contracture. Its mechanism was very difficult. First of all, how this mechanism developed. Normally, in all these cases, we'll see first web is contracted. In this case, first web was not at all contracted. You bent upon asking the question, the Z deformity. It was not a Z deformity at all. Z deformity in the thumb, in the fingers, and other things are there. Now, in this case, another difficult question which was there. Now, in all these cases, the volar aspect down there, the anterior capsule is totally really tight. Now, this case cannot be managed without a flap cover gun. Sometimes these are so bad that you might have to do carpalectomy in these cases to put it straight. Now, these are very bad contractures, very badly managed. Second question was asked, can we correct all these deformities? Yes, we should try to correct all these deformities. One stage. The two things which has to be corrected, that is the volar aspect of the wrist and dorsal aspect of the MCP joint. These things should be corrected simultaneously, can be done. Now, if suppose you use the joint flap or use the free flap, now in all these cases, both flaps can go dorsum and the volar aspect of this thing. Long flaps can be put it down there. Now, this will manage. Otherwise, we will be completely managing this thing. Third thing, now in all these cases, the botanial deformities were there, and the IP joint at the same time can be put on a more correctable position at the one step. A totally absolutely flat, they can put on more completely corrected position. Now, these things it is down there. Though all boys and girls, they did very well. Most of the people put it down, it's very nicely. But I thought today, some people ask questions in a way which is derogatory to the students, which people try to show their own intelligence, which is not fair. Please do not mind. And if I have hurt anyone, I put my apologies to them.